consultant in charge is Dr. Karthik. So I'm presenting Mr. X, 26-year-old gentleman, student in Gujarat, hailing from Vellore, who presented in November 2020 with complaints of cough for 3 months, weight loss which was not quantified associated with loss of appetite for 3 months, fever documented since 2 days, and altered sensorium for 2 days. There was no history of seizures, loss of consciousness, headache or vomiting. There was no history of rash or skin lesions noticed, no abdominal pain, loose stools or any urinary complaints. There is no history of exposure to sputum positive patients. There is no history of any drug abuse or significant past or family or personal history. On examination, his vitals, his heart rate was 100 per minute. His respiratory rate was 28 per minute, saturating 100%, requiring 31% venturi. His BP was 100 by 70. General physical examination, he had no clinically palpable lymphadenopathy, and he was noted to have oral candidiasis. CNS examination, he was drowsy, however arousable, and with intermittent disorientation and irrelevant talk. He had neck stiffness. He was moving all 4 limbs with no sensory loss, and deep tendon reflexes were present. On lower thoracic spine examination, there was tenderness. Respiratory system, there was bilateral scattered crepitations. CVS and abdominal examination was not contributory. So from this history of 3 months cough and fever, the differentials that we initially considered was a disseminated tuberculosis. Because he had oral candidiasis, we were also considering HIV with other opportunistic infections. Pulmonary complaints, so we were thinking of sarcoidosis if it's a systemic vasculitis, any autoimmune disorder, or if it's a primary or secondary lung malignancy. The initial investigations done showed a mild thrombocytopenia of 1,05,000 counts. His LFT had a mild transaminitis of SCPT of 101. His urea creat was normal. His CSF study showed mildly elevated WBC of 6, which was mainly lymphocytic predominant. 12 out of 25 WBCs. His glucose and proteins were grossly within normal limit, 49 and 46. And bacterial culture, multiplex viral PCR was negative, and his BBVS was negative. We proceeded with sputum examination, and his sputum detected Mycobacterium tuberculosis, which was rifampicin sensitive. Abdomen.
Ria, your voice is breaking. Ria, your voice is breaking. Hello.
Yeah, come now, John. Just see.
Can you hear me now, sir?
Ahead now. Now you can go ahead.
Yes.
I can hear you.
Okay. The psoas collection was also aspirated, which also detected Mycobacterium tuberculosis. We did an MRI for the patient, which was showing features of nodular lesions in the left frontal, in the pons, and the right cerebellar lesions. In keeping with the other findings, we were considering a CNS tuberculosis also in him, and we did a bone marrow, which also detected mycobacterium tuberculosis, which was rifampicin sensitive. Based on all this, we started weight-based ATT for him along with steroids on 3rd of December 2021, and the patient was discharged. 2 weeks after discharge, he presented back to us with fever for 1 week, vomiting for 1 week, jaundice for 1 day, and altered sensorium for 1 day. On examination, he was tachycardic, he was tachypneic, and general system examination and general physical examination systemic review was not additionally contributory. Now, with these complaints, the differentials we considered was a paradoxical worsening of the disseminated tuberculosis, if it was an ATT-induced hepatitis, if it was an HLH secondary to TB, or if it's a secondary bacterial infection with sepsis. So the investigation showed a pancytopenia with a hemoglobin of 8, total counts of 800 with a platelet count of 20,000. His LFT was deranged with transaminitis, direct hyperbilirubinemia. His INR was 1.99 and APTT was deranged. CT brain was done, which did not show any features of hydrocephalus or any new findings. Electrolytes, he had a hyponatremia, which was a depletional hyponatremia with a potassium of 3.3 and a bicarb of 20. Considering HLH, we had sent the further investigations. His ferritin was noted to be 44,297 with elevated triglycerides, decreased fibrinogen, and soluble CD25 was more than 44,000. A bone marrow was done, which showed moderately hypocellular marrow with poor cell trail and dilute refined imprint showing occasional foci of hemophagocytosis. So along with all these investigation, he had fever, he had cytopenia, and his ultrasound abdomen was also showing splenomegaly. So he fulfilled 7 out of the 8 criteria for HLH. In view of deranged LFT, we had changed him to hepatosafe ATT with ALE regimen, and later he was rechallenged with rifampicin isoniazid and pyrazinamide, and he was continued on steroids. Steroids was given according to the HLH 2004 protocol, and along with this, we gave 1 dose of IVIG also to the patient. He was symptomatically better, and later on the follow-up, we noticed that all his cell counts were showing an improving trend. And by 16, the patient was discharged, and we recalculated the ATT from which HRCD was restarted for him. And then we had planned a tapering dose of steroids, and he was discharged again. Now, 1 month later, again he presented to the OPD with history of fever for 3 days and sore throat for 3 days. On examination, he was hemodynamically stable. He had congested throat. He was readmitted for fever evaluation. His swab taken was positive for influenza A. His blood cultures were negative. So we treated his influenza A with 5 days of oseltamivir. But however, in spite of the treatment, he persisted to have fever spikes, and his procalcitonin was also on a lower trend. So we do not know what was the cause of his persisting fever spike. Again, when we evaluated him, his the pancytopenia that was resolving when during the previous discharge, again he had a recurrence of decreased cell counts and pancytopenia. Considering this, and to the known fact that influenza A can cause a reactivation of HLH, we again did an investigation. Again, he was fulfilling the criteria for reactivation of HLH. So at this point of time, we started him on steroids, and he received 2 cycles of IVIG, which was spaced over 2 weeks. And with the second cycle of IVIG and steroids, his fever subsided and his counts were improving. So I would like to discuss about HLH, the diagnosis, the secondary HLH which is seen in TB, and the treatment that we can go ahead with such patients. So HLH is a fatal hyperinflammatory syndrome associated with aggressive activation of macrophage and cytotoxic T cells, which will finally lead to immune-mediated multi-organ injury. So there is primary and secondary HLH. Primary is due to genetic mutations with decreased immunological power in those patients, and secondary HLH is usually secondary to infection or malignancy, or it can be because of autoimmune disorder. And according to one of the study, there is almost 50% mortality in TB-associated HLH if the diagnosis or the treatment is delayed. So the diagnosis of HLH is according to the HLH 2004 criteria. So there can be primary HLH which can be diagnosed by molecular study, where we do next generation sequencing in CMC, or there are other clinical criteria. If 5 out of the 8 is fulfilled, that is fever of more than 38.5 degrees Celsius, splenomegaly, cytopenia, either of 2 of the 3 lineages with hemoglobin less than 9, platelet less than 1 lakh, and neutrophil count less than 1000, hypertriglyceridemia, which is more than 265, and hypofibrinogenemia less than 150, with the hemophagocytosis seen in bone marrow, spleen, lymph node, or liver, with lower absent natural killer cell activity, and ferritin more than 500, and elevated CD25. Now, looking into various case reports which have documented TB with a secondary HLH. So we went through few case reports. So there are few which were published in 2020, in which a patient presented with disseminated TB who was treated with IV etoposide, that is twice a week for 2 weeks and then once a week for 6 weeks. And he was also started on steroids. The patient was not started on steroids, and the patient was noted to have a response by day 17. Another Indian study, which was a case report which was published in 2014, was of a 35-year-old lady who was sputum positive with features of dissemination, who was treated with IV methylpred pulse for 3 days, followed by oral steroids, and the patient was seen to have improvement. However, there was another 2 case reports in which there was disseminated tuberculosis, where there was a delay in diagnosis and delay in initiation of ATT, where in spite of starting steroids, where the patient had succumbed to the illness. This is another case series of 8 cases done in China, in which they have identified 8 patients with TB who developed secondary HLH, who was treated with multiple regimens using steroids, methylpred, cyclosporin, and IVIG. But we see that most of the patients had succumbed to the illness irrespective of all these treatment. This is another study which was published in 2015. They had gone through literature review from 1975 to March 2014, and 64 cases were identified with TB HLH, and the average mortality of all the cases were 49%. And we see that according to the age, the comorbidities, there is a worsening prognosis if the age is more than 30, and if the patient is have associated comorbidities, and initiation of earlier ATT has a significant prognostication value and significant improvement in those patients. And immunotherapy, though statistically it was not significant, but the patients were noted to have. Hello. Moving on to the treatment. So, according to the Histiocyte Society in 2004 guidelines, the treatment recommendation is initial therapy of 8 weeks with steroids, which can be started at 10 mg per meter square for 2 weeks, and then taper every 2 weeks by 5 mg, 2.5 mg, and 1.25 mg, and then stop the steroids. And then once in 3 weeks, DEXA 10 mg per meter square has to be pulsed. Now, this is mainly for primary HLH, whereas in secondary HLH, the recommendation is. Okay.
You might have to wind up soon.
So okay, sir. So let's go through the HLH. So whenever there is a patient who has a secondary HLH, if it is infection associated, the treatment regimens that we can have is, if it is a viral infection that is precipitating it, the recommendation is either corticosteroids with etoposide or a rituximab. And if it is because of a intracellular pathogen like Leishmania or TB, we did not give second line immunomodulators, can treat those patients with the supplemental corticosteroids and IVIG. So in our patient, we continued him on ATT. We restarted HSLD with rechallenge and started him on steroids and IVIG. However, in few of the fulminant cause with the multiple admissions and flares, primary HLH mutation analysis is also sent, which is awaited. We are following up the patient in OPD. As of 2 days back, his counts have normalized, and he is planned on continuation on the intensive phase of ATT, and it will be tailored according to his clinical response. So the take-home message will be there are better outcomes for secondary HLH as compared to primary HLH, and there should be a slow tapering of steroids, because we were considering, along with influenza A, maybe the fast tapering of the steroids provoked his relapse or recurrence of HLH. And we also wanted to focus on the diagnosis and the therapeutic options that can be given in secondary HLH. Thank you.
Thank you, Dr. Ria. Any comments from Dr. Karthik?
Actually, we want to emphasize on the entity of secondary HLH and TB, which we are commonly seeing right now, and the need for tapering of steroids based on clinical response rather than going by a strict protocol. and use of IVIG in this case, because this patient had a second episode of HLH, which was probably precipitated by the influenza A infection that he had, and role of IVIG and steroids. And etoposide is not used in patient with TB where they had poor outcomes. Other option is to give cyclophosphamide, that also based on case by case basis.
What
That's all.
dose of IVIG did you use?
So
400.
yeah,
Sir, we used 400 mg per kg,
400
sir.
mg per kg.
Yes. Yes.
In the first time.
We
And
gave him
you
weekly
gave
pulse
3
for
times
2
totally,
weeks.
no?
A total of 3 times. Each time, sir, 400
Each time
mg.
400. Okay. And over 1 day itself?
Over 1 day, sir. And the second dose was repeated after 1 week when he had the relapse.
Thank you. Thank you. Thank you. Any
Audible,
comments
sir?
from anybody else on this? We're running a little behind time, so I'll invite Medicine 1, Dr. Aishwarya.